Hi everybody, welcome to this evening's fertility interview series. We've got the amazing Dr Alison Gee joining us this evening. So I'll just give you all a little bit of time to jump into the live. Thank you so much for joining us, everybody. As I said, I'm so excited to have Dr Alison Gee joining us this evening. I can see she's just in there, so let me just see if she can request to join, or if I can ask her. Dr Alison Gee. Okay, I'm just going to pop in a request and then hopefully she can just jump on from there. So while Dr Gee's joining us, oh, there you are. Hello, how are you?
Hello, Linda. Nice to see you. Well,
yeah, thank you for joining us. I was just about to give a bit of an introduction, about you. So I'll just do that while everybody's jumping in. Again, thank you so much for giving up your Wednesday evening to chat to us. I know that there's lots of people that are really excited to hear from you.
pleasure.
Dr Gee is an amazing fertility specialist with Genea. She's also recently taken over as the head of Department of Reproductive Endocrinology and Infertility at RPA, Royal Prince Alfred Hospital, which is so exciting. So you're running the public health IVF unit there, is that correct?
Yes, that's right. Yeah, so we have a department of reproductive endocrinology and infertility, and we have an IVF service that runs through that. So,
Yep.
so I have to look after that, and we've got a good big team of doctors there as well. So,
yeah, absolutely. And I think there's a couple of questions on sort of public and private, so we're going to chat about all. So look, I've been, recommending that a lot of my patients see Dr Gee for many years now. I absolutely value her caring nature, professional, sort of really patient-centric, treatment and really, your success rates, and I see it, time and time again. When people come and see you, I know in Australia we don't have doctor-specific rates of success, but I feel like yours is definitely up there, which is amazing. And all of my patients come back having seen you going, oh my gosh, thank you, she looked at everything, she took the time. Some of them are even like, she had all my results in a little spreadsheet.
That's very Linda.
Yeah, it's true. Like it's amazing. And I think a lot of people think that IVF and fertility treatment is a one-size-fits-all approach, and that whoever you're going to go to is going to do the same thing. And like in any area of medicine, hairdressing, naturopathy, like anything, there's like a million different ways of doing things, and everybody has different viewpoints and things like that. So thank you so much for taking time to join us tonight.
Oh, thank you for inviting me. I've been wanting to catch up with you actually, Belinda, so it's very nice. Yeah.
It's always through mutual patients. A lot.
Yes, we have a lot of common patients, and I appreciated that your care for all of the patients of mine that see you as well. Yeah.
Thank you so much. Thank you. So as usual, we've got a bunch of questions. I know we've got people watching live this evening, and people there's always hundreds that watch back as well. So if the people that are with us live this evening, feel free to pop any questions in the comments box the question box down at the bottom, and we'll absolutely try to get into them. Dr Gee, is there anything that you feel like, before we kind of get into it, that is something that a lot of people want to know, or a lot of people don't know, or something that that you are looking into or seeing a lot more of at the moment in fertility treatment?
Well, actually, I think, Belinda, you probably touched it on your introduction in a little way. I think I often see a lot of patients who have had, unfortunately, who have had not as much success as we would like for them, particularly doing IVF or assisted reproduction or fertility treatment. And so I think that's one area that people really, are looking for information about. They're looking to find out sort of, why is this, why are we not getting pregnant naturally? Why is, fertility treatment not working for us? What else could we be doing personally? And I think that's where your role comes into play quite a bit. What can we be doing to optimizing our sort of, our lifestyle factors. And then they want to know what can they be doing to optimize their fertility treatment. Have they had all the investigations that maybe, that might be warranted? We've sort of looked at other medical aspects of their history that might be relevant as to why they're not getting pregnant. and somebody needs to look into some of those rarities that don't happen too often, that do happen to some people, and that just need to be addressed or looked at, or even if the box is just ticked off and we know that's not a problem. So I think what I see is a lot of patients who are just coming for, a second opinion or a second set of eyes. And, I think that's where a lot of interest lies. A lot of people searching on the internet comes about too, in terms of, why isn't it working for me? And what can I do to try and improve my chances? Or, where can I go to try and get some help with it? Yeah.
Yeah. And such a blessing and a curse, the internet, isn't it? Like we can information. It's not always relevant to people individually. And, I think that's why having a team and somebody that you can trust and work with to know, look, that test is probably maybe not relevant for you yet, or this is, or, it's hard probably to, yeah.
No, I think that's right. And, there are some clinicians that will look closely at one area and others that might look at another area. And so I think it's important that, for anybody doing fertility treatment, that sometimes it is good to get a second eyes on things just to make sure that everything has been done. So I think all of those things are really important. And sometimes it's just, so I think that's probably the most, common group of patients that I see. And maybe that I'm just showing my aging a little bit, is patients where, they've, because a lot of patients, some patients will get pregnant very quickly if they're doing fertility treatment. Some patients won't even need to do assisted reproduction, and others will be struggling a little bit. And I think they're the ones that you do that really need the time taken to make sure that, everybody has done their best to try and achieve a positive outcome for them.
Yeah. And I would have to say a lot of my patients that go to you for a second opinion, I would say 99% end up with you. The most difficult thing about Alison, everybody who's wondering, is just getting in. I often create a bit of a roadmap with my patients. And I'm like, okay, so look, if this one doesn't work and whatever it is, maybe then this, I'm always like, put in an appointment with Alison. You're probably not going to get in till next year or maybe the end of the year. And if you don't end up needing that appointment, that will be the best cancellation.
Well, that would be and we're not that difficult to go and see.
Like in terms of like, you're busy because, not that difficult. But, in terms of like, you are really kind of like really highly sought after, which is, an absolute kind of, credit to you. So I'm just going to quickly look here and see, somebody's just saying, I just want to send massive thanks to Dr. Gee. Because of her, my husband and I will be able to have a beautiful baby via surrogacy. Lots of love, Dr. Gee, Josh, Jack, and Ari. Beautiful. Okay. Yeah, nice to have some feedback and people.
It's always nice to have news, isn't it? Yes.
Totally. They're the emails, calls, whatever to get, isn't it? Makes
it always, yeah. And they're not always good. There's sometimes, and it's not always good news with fertility treatment. So it's really lovely when it does work for couples. Yeah.
Yeah. Oh, it's beautiful. So thank you guys for joining in, even though maybe you're not trying to have another baby. Maybe you just wanted to see Dr. Gee chatting, which is fair. Okay. So we'll launch into some of the questions. There's always kind of common themes, but everybody's always to kind of hear different perspectives, different takes, so that they can just gather that information.
That's right. And get another opinion sometimes as well, I think. Yeah.
Absolutely. Okay. So is it possible to improve egg quality is one of the questions we always get asked.
Look, and you, Belinda, would probably get that question quite a lot. And look, I'm of the opinion that it certainly is. It is possible to improve egg quality, and I think that's one of the first things when you're sitting down with a couple where they may be struggling to achieve a pregnancy, is to look at things that might be very beneficial in terms of both sperm and egg quality, because they do go hand in hand if it's sort of a male and female couple that are presenting, or just for females. And so I think the first thing, and everybody's probably knows I'm going to say that, is to look at the lifestyle factors. Look at things like weight. Which is very important, if you're overweight or if you're underweight, and what might be underpinning that. So somebody may have some issues with their glucose or insulin metabolism. There could be thyroid issues that are playing a little bit of a role in that. So they're all very important things to look at. Other lifestyle factors, smoking is an obvious one. Things like excess alcohol consumption, any other drug use. So I think they're all really from the very first time I meet a couple there, that's probably the first thing that we want to take a history of and want to address, because just by just by addressing lifestyle factors, couples that may be all they need to do to achieve a positive outcome. They may not need to do anything further in terms of their infertility sort of journey. And the same goes, the same things go for men. Weight, alcohol consumption, smoking, heat exposure to the testes. So they can all improve both sperm and egg. And then there are other things and look, to be honest, there isn't really any test. What's the true test for egg quality? Well, it's whether or if somebody's if they're trying for pregnancy, are they able to achieve a pregnancy? So sometimes in infertility treatment, we don't really get a good look at eggs until we're sort of in the IVF setting and you retrieving eggs, and we're seeing whether they're fertilized and whether they're making embryos. And it's at that point that you can then say to couples, well, maybe the embryo development's been a little bit suboptimal, and what other adjuvant therapies might be helpful in terms of improving the quality of the eggs. And that's when we start looking at some of the supplements that I think are helpful for egg quality, but they're not always necessarily supported by large randomized controlled trials in the IVF setting. And that makes it, that's sort of fine line, isn't it, in terms of, what to prescribe and what's the evidence base for that. And that goes to things, Belinda, that you're very familiar with in terms of, suggesting things like coenzyme Q10. I mean, for years there were no studies on it. There is one reasonable study looking at CoQ10 prior to IVF treatment. Things like NAC, inositol or L-arginine, things that they're not going to be useful necessarily for all patients, but for some patients they may make the difference. And I think the first rule of thumb with a lot of these is to sort of say, well, look, first you want to do no harm. So you want to, make sure that that you feel somebody does have an issue with either egg quality or sperm quality before we start sort of adding a lot of those things into the mix, because they may not be required. But if you come to that point, you think that might be underpinning the infertility, then I think it's quite reasonable. And there are some other adjuvants that we're now getting quite a number of studies looking at sort of androgen supplement prior to IVF. So things like HEA and testosterone gel. So I certainly don't think that every patient has a problem with the quality of the eggs, but I think any patient undertaking infertility treatment wants to maximise their opportunity of success. And I think to do that, it's looking at all of those factors that are going to improve the outcome. And certainly, so from my perspective, I think that's one of the things that I do like to look at is, can we improve the outcome for couples on their fertility journey by improving eggs and sperm and sort of all of those lifestyle factors that come into play and consideration of supplements. So yes, I think you can improve for couples and for.
And we see it clinically all the time, and you must kind of see it too, right? Because often, I've had patients say, Dr. G said, go off and take your supplements, whether you might be on DHEA or whatever, for kind of 3 months and kind of come back. And, we do see, not always, absolutely, but, people know that nothing is a guarantee, which is unfortunate. Yeah. But everything that they can do to optimize. And,
well, I think that's right. Sometimes they have been trying for quite a while. And I do say, well, look, I think it's just, take a break, take this and 3 months, and then we'll have another go. And in that time, we've certainly I've had patients that have even achieved a pregnancy naturally. Now, some of the adjuvants and supplements that are used for to try and improve quality of eggs do need to be stopped when you're pregnant. So it's very important to give that, I'm sort of always very careful about giving advice. If I'm prescribing a patient an adjuvant such as DHEA, it's important, that they stop it if they return a positive pregnancy test, or we stop it at the time of embryo transfer. And I think the other important thing is they're not long-term, supplements. I mean, some are absolutely fine to take, and a lot of your recommendations, Belinda, are very sensible. things like fish oil, and of course, everyone needs to be on their folic acid and all those sort of things. And other adjuvants, such as the androgens, are just they're only very short-term medications or prescriptive medicines that are prescribed just prior to going into an IVF sort of cycle. So they're not to be on for months and months on end. My
build up in a right, like it's you just get a certain level, and
and I think they will either work or they won't, and it's about being very honest about those if we're looking at trying to improve the quality of the eggs, and some of them will work for some patients and others won't. So look, but I think for some patients it's definitely one of the things that you do need to consider, and for all patients at the outset, particularly in terms of those lifestyle factors.
Yeah. And I think there's some doctors sort of believe you can change egg quality, some kind of don't. But, you know, we there are studies kind of coming through, and hopefully there'll be more and more. But, you know, I imagine it's also hard to recruit and everything.
Well, there are, and they look at some studies. There's some mice model studies on NAD, as you're probably aware of. So I think, and look, you know, I think the area will, you know, continue to expand as everybody looks, you know, in all areas for the sort of, you know, the fountain of youth and how to reverse aging, and a lot of those supplements come into that sort of area, really. So I think
for before this is always that, you know, kind of anti-aging type of things.
Yeah.
And so, you know, obviously we talked about egg quality, and I think a lot of us will know that sperm quality is probably even more susceptible to diet and lifestyle and things like that. You know, smoking, like you mentioned, vaping, I feel like that's just like becoming big. And
smoking, vaping, you know, other drug use, alcohol consumption, you know, is very important to sort of, you know, look at those guidelines for alcohol consumption, particularly for men, sort of 8 to 10 standard drinks per week. You know, weight is another factor that can certainly affect the quality of the sperm. And, you know, I think that's when couples are presenting and they have, you know, had a bit of a fertility journey, it's always good to take a step back and just have a look to, you know, has the sperm DNA fragmentation been assessed? And a little bit unlike eggs, with sperm, we do get a little bit of a window into the quality of the sperm. You can do sperm DNA fragmentation testing. So all of the DNA is packaged in the head of the sperm. There are a couple of tests that can assess that. Now, no, there isn't the perfect test either for the quality of the sperm. And again, you know, it really is going to be coming down to whether a couple can achieve a pregnancy. But I think that's one factor that you can certainly look at. And there are some sperm selection methods which are used in the IVF setting for men who do have elevated DNA fragmentation, which can be very helpful. So I think it is something that you want to look at. And, you know, if the DNA fragmentation is elevated, then it's, you know, very good opportunity to sort of to actually take the time and say, well, let's try and lower that. And there are some studies looking at antioxidants for men, so high-dose vitamin C, vitamin E, CoQ10, men's multivitamins. So that evidence is kind of all that, you know, studies looking at that are quite out there in the literature. And that is one test which I think is very helpful to guide that sort of, you know, treatment if it's needed for the sperm. Whereas for eggs, we just don't have a similar test, unfortunately.
Yeah, so everything gets thrown back on the poor old egg. Yeah. And a lot of people haven't had that DNA fragmentation done. One of the questions which isn't I'm going to ask is, what are your thoughts on, you know, the DNA frag's fine, the semen analysis is fine, but yet that partner is still, you know, drinking or maybe smoking or not kind of so healthy?
Well, I think that's a really good question, Belinda. And what I often say to patients, particularly you know, men if they're smoking, is obviously the first thing I'm going to say, stop smoking. And I say, and we're going to order the DNA fragmentation test. But just because it comes back and it's normal, it doesn't mean that it's okay to continue with the smoking or the high alcohol consumption, or, you know, maybe some poor lifestyle sort of choices. And the reason is that that's only one test. We don't have a test for every aspect of sperm health. And so whilst the DNA fragmentation may be normal, there are other things that may be affected by those, you know, by heavy alcohol consumption or by the smoking and the vaping that we can't see. And so, but particularly, you know, when you're trying for pregnancy, I think it really is, you know, you've got to do everything that you can as a couple. And so I do precede handing out that test to anybody is engaging in some lifestyle factors that I think could benefit from a review and cessation, then to say, look, just because it's normal, it doesn't mean that it's, you know, that I'm going to say it's okay. But if it's abnormal, I'm going to say add in these extras as well. Or
hard one, because people see that and go, it's fine. You know, I always say to people, you know, if you saw somebody who was like super unhealthy, maybe overweight, drinking, smoking, but their bloods were fine, like they didn't have diabetes, their cholesterol was fine, whatever, it doesn't mean they're healthy. You might look at them and go, I can see that you're not.
That's right. I think really
changed.
I do, and I think that's really important. And sometimes you may even see it in the embryology that comes out. You know, that you might, you know, fragmentation might be normal, but we do see couples where we're still not getting, you know, the sort of embryology results in the IVF that we'd like to see. And you've just got to make sure that all of those factors have been addressed when you go into it. And look, for most couples, they genuinely do want to address those. There aren't that many that when you sort of suggest it are not going to be on board, because particularly if you get to that point, you know, it's best to avoid IVF if you don't need to have any sort of assisted reproduction. So, you know, most couples, they want to try and avoid that sort of road. So they're going to really want to try and address all of those things, and are usually generally receptive to the advice. And if they're not, the partner's very receptive that somebody else is giving that advice, so that advice has been definitely given. Yeah. And everybody's been on the same page with it.
Yeah. It's hard though, because not everybody tells the truth, because a lot of people come here and go, oh, I said that I wasn't da-da-da, but like, it's not true. And you're like, I'm always like, your doctor doesn't care, but like, they're not losing any sleep over it. They want to help you.
No, and that's a bit being open about the conversation when you have with patients, is just trying to, nobody's perfect, and it's just trying, and you try, and and everybody's trying to help achieve the same outcome if it's sort of looking, from a fertility perspective. So, I don't, and it's better to know. Yeah.
Way better to know. Exactly. Yeah.
Mm.
Okay. So, somebody said here, 75% of embryos being abnormal at age of 32. Can this be improved, or is that normal?
So that's so look, my assumption is that this patient has undergone IVF treatment, and they have had embryos created, and their embryos have been grown to what we call the blastocyst, or the day 5 development stage. And and so what you can do with those embryos is that we now have the opportunity. So embryos, so we go from a 1-cell egg to a 50 to 100 cell embryo by day 5, which is quite incredible. So embryos sort of rapidly dividing. Now the outer cells form the placenta, and the inner, called the trifectoderm cells, and the inner cell mass form the baby. And we have the capacity now that we can sample some of the trifectoderm cells and freeze the embryo, and the embryo is still very viable after the freezing, or the majority are. And we can test those cells, and we can have a look at chromosomes. So normally in every cell in your body, there should be 23 pairs of chromosomes. So we can take 5 cells from an embryo, and to an accuracy of about 95%, we can tell whether that embryo has a chromosome too many or a chromosome too few, which is quite incredible in itself. And so that can sometimes guide patients doing IVF. And it's been, I think over the years that I've done IVF, it's now very helpful, because we now know when we're putting embryos back, are embryos normal or not? And particularly for patients with recurrent implantation failure, we used to just say to them, oh, look, well, your embryos are just, the embryos are not good, they're not good, have another go. But now sometimes we can see that actually the embryos are normal, so there must be something else that might be causing the implantation failure. And I think that's been very helpful, opening up to a range of other reasons that patients are now that we explore for implantation failure. But back to the question about 32. So when we look at embryos that are normal, the patients who are aged 30 years or less, about 70% of the embryos, so when we biopsy them, are generally genetically normal. And as women get older, that number sort of increases. So for women who are aged sort of 35 to 37, about 1/3 of their embryos will be abnormal, and 2/3 will be normal. Once we get to 38, 39, it's sort of getting towards that 50% normal, 50% abnormal. And we get to once you're over 40, it's sort of 60%, and you get to 43, it's about 75%. And it's interesting because the rate of chromosome abnormality in embryos increases as age increases. And you can see our pregnancy rates declining both naturally and in the IVF setting. So it's very difficult when somebody might have, say, so our patient, 10 embryo, that would be a lot. So say somebody had 5 embryos biopsied, and they were 32, and 3 of those were abnormal and 2 were normal. Well, that's only 5 embryos. So, the next time somebody did an IVF, that same patient did an IVF cycle, they might have 4 that are normal. So if it's only small numbers that we're looking, I'd say that it's not necessarily abnormal, it's only 1 cycle. The very good news is there's some normal embryos, so that's a great opportunity, in terms of pregnancy. And it's probably not enough to make a sweeping statement to say that's probably underpinning the infertility. But there are genuinely some patients that are going to make an abnormal number of embryos with chromosome abnormalities, and we see those in patients with recurrent pregnancy losses. And sometimes we don't have a reason why. So it's always important, and generally before patients actually have the genetic testing of embryos, always check that the genetic or karyotypes for male and female, so we check that they're normal. And then back to the question of, is there any way you can reverse this? Well, that's a very tricky question. And I think that goes back to really what we've been saying from the very beginning of tonight's conversation, is looking at the quality of the sperm and the egg and how can that be improved. and do any of the supplements sort of aid with that process. And it's very interesting. Some of the initial studies looking at the androgen adjuvants, so DHEA, when they were giving them to women who weren't getting large numbers of eggs. And when they looked at the original study, some of the studies, women weren't necessarily getting more eggs when they took the DHA, but there was a higher pregnancy rate. So some of these supplements must be doing something that are aiding that process in terms of follicular genesis, or is it the spindles attaching onto the chromosome? So I think there are some processes that we don't have all of the answers for. What I would say is the fact that there are some embryos that are normal is very encouraging and an excellent opportunity for pregnancy for somebody in their early 30s. And unless it's always good to sit down with your fertility consultant if that's your situation and sort of have that conversation. But when we look at the statistics, we probably don't have enough to say for that particular patient's abnormal, but that's sort of the way they sort of run.
Yeah, and it's hard to say 75% because it's how many cycles have you done, and if you've done loads and you've got 10
that's
and
right.
3 normal, whatever it is, like that's still
right. And really for some, that might be why you are doing the IVF, and that might be the advantage of the IVF is that selection, and to have normal embryos then in that case is actually it's going to be hopefully a good outcome in your early 30s.
Yeah, absolutely. So good luck to that person there. Okay, so that was that question. Okay, so a couple of others. So we've sort of talked a little bit about how to prepare for the IVF process in that. What are your thoughts on embryo glue? Is that worth doing for a frozen embryo transfer?
Oh, look, embryo glue is interesting. There are some units that do regularly use embryo glue, and the basis of that was some studies that had come out showing actually quite reasonable improvements in sort of pregnancy rates for units that were using embryo glue. So embryo glue is actually high hyaluronic, so high hyaluronidase, and it's sort of, I think we call it a macromolecule that's sort of found.
Eye creams.
Yeah, that's right. In the tubes and in the uterus, and it's thought to be helpful for proliferation or migration and adhesion, really, and that's why it has been used in the embryo glue, and it's thought that actually that peaks around about day 5, and that's why it's used when you're transferring an embryo back into the uterus. Now, look, as I said, I think the studies are still quite variable in terms of the outcome with embryo glue. And it's also quite expensive when you're using it for fertility treatment. As I said, there are some clinics that use it regularly. The clinic that I work at, we don't use it regularly. I personally do use it for a select group of patients, and the patients that I have tended to use it for are patients who have recurrent implantation failure. In that setting, to see if that might aid us when we have sort of looked at many other avenues that haven't achieved success. I think it's reasonable to look at embryo glue. It's not something as a standard that I think everybody needs embryo glue, but there is certainly maybe a subgroup of patients that might benefit from consideration of embryo glue. And I think that's a conversation then to have with the fertility specialist, in terms of whether you're one of those patients that you should consider using the embryo glue.
I think the name sounds very attractive.
What, embryo glue?
Yeah. Like just being called that, it's like, oh, I want to go on it. Like that, I need that.
Right. It does sound very attractive because your embryo is going to stick, and you can see now that's the basis of why it's used. But I think
like, oh, do I need hyaluronidase? Probably not. But do I need embryo glue? Yeah, I need that.
Well, that's right. And but I think it's worth having a conversation if that's your situation. And as I said, there are some fertility clinics that use it regularly, so some patients might find that that's a standard at their fertility clinic.
Yeah. And if patients want to use those sort of things and there's no harm and they're happy to pay, like, is that something that they can request or not really?
I think so. I think, well, you can certainly request that, I think. And as I said, some units use it all the time. What I think is important is that patients aren't being upsold in terms of fertility treatment. So, if it's your first cycle and you're young and, it's a male factor or there's tubal disease, I actually don't think that you're going to need embryo glue. And so even if you requested it, I would be very honest and say, no, I really don't think that you need embryo glue. Now, that's a very different story to someone who's had, all of the tests done and, laparoscope looked at sperm, they've looked at, putting normal embryos back and they're not implanting. Well, I think that's a different situation, and that's when I personally might consider embryo glue, but other clinicians might consider it at another, at a different stage, you know, in terms of fertility treatment.
Or even what if, like, say somebody, for example, was like, you know, early 40s, they just were having cancelled cycles and they finally made an embryo, you know, or yeah, it's probably case by case basis.
Oh, I think so. I think you are like, you know, I always say to most patients, you've just got to take the whole history into account, and everybody's history is going to be different. And you just really need to treat the individual patient or, you know, the couple on their history and what you sort of, you know, what we know from the evidence in the literature and what we feel from experience is going to give them the, you know, the best outcome.
Yeah, I think that, you know, if you've got a specialist or you're working with a doctor that you feel like you can have discussions with, obviously you don't have every single discussion, but not everything shut down, but it's like, I hear you, this is why or not, but you know, we're trying this but not this, or whatever.
That's fine. No fertility minds that conversation either.
Yeah, maybe some do, maybe some. What would you say, or when should you do a hysteroscopy or consider a hysteroscopy?
Look, that's quite an open-ended question, actually, that one, in terms of a hysteroscopy. So what a hysteroscopy is a gynecological procedure where a small telescope is placed inside the uterine cavity and we have a look around. And so generally patients are asleep. There are some outpatient departments that do it while patients are sort of mostly conscious. But the majority of cases, a patient has a general anaesthetic and they're put to sleep, and sometimes a cervix, the entrance to the uterus needs to be dilated, and a little telescope is placed and we have a look around at the uterus. Now, there's sometimes that hysteroscopes are indicated from patients' pelvic imaging. So they might have, particularly if they're, so say in the infertility setting, if they're trying to achieve pregnancy and there's a submucosal fibroid that's abutting into the cavity, that might need to be removed. There might be polyps, and so you need to do that with a hysteroscope. So you put the telescope in, and then we have some instruments that help to guide us to remove a polyp or remove a fibroid. Sometimes patients have very thick endometrium that needs to be assessed, and that might be best assessed with a hysteroscope, and then we sample the lining. Some patients might have very thin endometrium, and we're worried about and sort of imaging suggesting of adhesions, and so then we need to pop a telescope in and assess the uterine cavity. Sometimes patients are having recurrent implantation failure, and you feel it is warranted to do a hysteroscope, have a good look in, sample the lining, check there's no endometritis or infection. So a hysteroscope can be a very valuable tool for patients who are having investigations for infertility, and sometimes it's clearly indicated, and sometimes it's indicated through treatment that may not have been successful, and at that point you might want to do a hysteroscope, have a good look in the cavity and sample the lining. You can actually sample the lining of the uterus without doing a hysteroscope, so you can put a little, it's called a PELS, a little catheter in that, a biopsy catheter, and we can just sample the lining more as in an outpatient setting. So you don't always have to have a hysteroscope to have an endometrial biopsy, but to actually have a look inside the cavity, then that does require a hysteroscope, and there's a lot of operative hysteroscope procedures that require the hysteroscope to be done. So there's a range of reasons to do a hysteroscope, I think, in the infertility setting and just in the gynecological setting generally.
Yeah. And when in the cycle should it be done? Like
generally, hysteroscopes, they're usually done in the first half of the cycle, and there's a couple of reasons for that. One is that the lining is thinner in the first half of the cycle, so it's often easier to see pathology. And the second is you don't want patients to be pregnant when you're doing a hysteroscope. So that's also a good time to do it in the first half of the cycle, and just, you know, couples that someone's sexually active, just avoid, avoid intercourse or barrier contraception until you've done the hysteroscope. So that's generally when it's done. It's a bit like pelvic ultrasounds are generally done in the first half of the cycle, and that's because the lining is thinner in the first half, so it's often easier to see pathology. And that's, so if anyone's wondering why the timing of that is in the first half, that's why.
And you can try afterwards too, so you don't miss a month, which nobody wants to miss a month. Yeah. Can you tell the lining receptivity of for an embryo in a hysteroscopy, or not really? You'd have to.
Well, really, there's a few things. So if you do a hysteroscope, that's just a look with the camera. So you need to do an endometrial biopsy. And an endometrial biopsy, if you sample the lining at any stage during the menstrual cycle, you can send it to the pathologist, and they can tell you, was it in the proliferative phase or was it in the luteal phase, and that can be helpful if you're worried a little bit about discordance in the endometrium. It's not actually an endometrial receptivity test though. So an endometrial receptivity test is a specific test that's been designed to look at the endometrial receptivity at the time of implantation, which is around about 5 days post-ovulation. And there are a few different centres that do endometrial receptivity tests. For me, if I do one, I need to send it overseas to be analysed. So there's a few companies that look at that, but one particularly that does that, and that's probably what's being referred to here. And so you send, so what we do is we track women's ovulation cycle. It needs to be fairly well timed. There's a few different ways of doing this. And then 5 days post what we take as ovulation day, we take a sample of the lining. And generally you don't need to do a hysteroscope with that. You can just do that with that little biopsy catheter, and then it gets sent off. And it gets sent off for a few markers that look at endometrial receptivity. So are we in what we think is a window of implantation? It also looks at some infection markers as well, and sort of lactobacilli. It's not a cheap test to do. Again, I think it's a test that I just use for a very small subgroup of patients in terms of the effectiveness of it as a tool for me, for fertility, doctors that might use it more commonly. And it generally is used in the setting of implantation failure with IVF is where the test has come about in terms of its use and popularity.
See, like, what would you say is that, I mean, you might know the actual percent, or you can just make it up. Everyone knows I always make up percentages, like of, because I would say quite a small percent of my patients who've gone and had that done with their doctor come back with an altered window. Like, there's a few, but it's not.
I think that's right, Belinda. There isn't many that come back. And actually what we do know is there is a window of receptivity for embryos in implantation. And at our unit at Genea, we've had a good look at embryos, that were frozen on day 5 and day 6, and the age of the patient and where we're getting our optimal pregnancy rates. And I think that window of implantation is coming into play to that. Where I have used it is for women where we've been actually giving them synthetic estrogen and progesterone. And failing to achieve a positive result, and that's a very repeatable sort of process. And so the timing is always going, and if we're not sure, if I'm not sure that they're actually, the progesterone that we're giving, how well is that being absorbed, you can actually test that on an endometrial receptivity test, and use that sort of if you found you're receptive, you can use exactly that medication regime to repeat that and put an embryo back the following month. And so for me, that's, and it's actually a little bit after that because it takes a little while for the test to come back. So it is a bit of a process. Yeah. But for me, that's where I found it to be most benefit. And so when I was saying it's a very small subgroup of patients, I think that's for me that probably the most benefit that I have found in that particular group. But I say that I haven't used it for other patients as well at times. Yeah.
Yeah. Yeah, it always just seems small to kind of come back. So, I mean, obviously, like you said,
a lot of them come back, and that's because a lot of what we do, timing is often accurate. But there is a small group of patients, and they're your recurrent implantation patients who've had a really tough time of things, and sometimes that's the test that you might want to do.
Yeah. And like you said before, there's those rarities, but we also, I always think it's, at some point it's sloppy medicine to go, oh, it's probably not that, like there's that group of patients who needs those things to be ruled out because they really have had,
That's fine. And sometimes it is ruling things out just so you can, so you can be reassured as a clinician, and you can reassure your patients that you've had a look at everything that might be important to them as a couple. And I think that's really important actually with the fertility treatment, is that you want to be able to have a couple, we've done our best for you to achieve a pregnancy naturally, and we've done our best, in terms of assisted reproduction. And sometimes it is going back and sort of going back to the beginning and saying, well, have we done our best to look at everything naturally? Or maybe someone needed a laparoscopy if they didn't have one. And so there are a few things like that are helpful. But doing something like the receptivity test is also important sometimes to say, well, look, we have done everything that we can absolutely look at for you.
And that's often what I say to patients is they're sort of feeling like they're sort of toward the end of the road is, get everything done so that if worst case scenario, you didn't, have a baby, by the time it was, sort of too late, you didn't look back and somebody goes, oh, you should have done this test, and then you're like, oh, we didn't, obviously it's got to be within your budget, and there's, obviously certain people that are indicated for certain tests and things like that.
Yes.
I think or know they've done everything, and obviously hopefully that helps them achieve their success as well.
Sometimes it does. Sometimes patients have done IVF and then they might go back and have, just for example, a laparoscope and have some endometriosis taken out, and then they achieve a pregnancy. And that's wonderful if that happens.
Yeah, feels like that happens a lot, but I'm sure, it doesn't happen. So Dr. Gee, what would you say the best treatment for endometrial hyperplasia? So you sort of mentioned a little bit on that before, where you sort of didn't talk about the history.
When you put the telescope in and have a look. Look, endometrial hyperplasia is, again, it's actually a fairly broad topic because, so what endometrial hyperplasia is sort of an overgrowth of the endometrium or the lining of the uterus. So the cells tend to lose their regulation and they start to sort of, grow and heap up a little bit. So, and there's stages of endometrial hyperplasia. So there's simple hyperplasia, there's a hyperplasia, complex hyperplasia, there's complex hyperplasia with atypical cells, and then we go on to sort of the endometrial cancer, which is a nasty end of endometrial hyperplasia. So it does need to be looked at. So usually it's diagnosed with often a hysteroscope and an endometrial biopsy. And simple hyperplasia is, so the treatment of endometrial hyperplasia is progesterone therapy. And it can mean quite a period of time with progesterone therapy. It could mean up to 6 months, and that can be either by a Mirena IUD or by an oral progesterone tablets, and then the lining needs to be resupplemented because you actually need to, you don't want to have endometrial hyperplasia if you're trying to achieve a pregnancy. Often if someone's had a hysteroscope and they've just got simple hyperplasia, well, that's generally okay after counselling, and it really depends on, again, everyone's circumstance to look towards fertility treatment. In other circumstances, there might be some clinicians that do want to treat that with some progesterone therapy. Anything more than that, though, really needs to be treated with progesterone. So we normally use a Mirena IUD or high-dose progesterone for 6 months, and then the endometrium is sort of reassessed. So that any treatment with any endometrial hyperplasia really needs to be treated combined with a gynecologist, fertility specialist, and so that's the sort of course of events. And it can be frustrating if patients have complex endometrial hyperplasia, and they need to step back from any fertility treatment they might have been doing for several months and have that treated and then progress to fertility treatment. But I've got a number of patients who've had successful treatment of their hyperplasia and then come back and we've gone, and you're pretty much straight into their fertility treatment with successful outcomes. So I think the hyperplasia really depends what type of hyperplasia it is. And that needs to be discussed with a gynecologist or a fertility specialist, and an individualised treatment needs to be made on that basis as to what sort of hyperplasia it is. Yeah.
All those things that, require months off and things like that are very
they're frustrating, aren't they, for couples?
Hopefully treated and,
Well, that's right. And it's just sort of then looking, having a plan, what to do once you are at that point. And I think that's the next important step, is to have that plan.
Ready to go. Is there an option? Is there always an option to go on with IVF? When do you say no?
Look, that's a tricky one, I think, because it's a very hard thing to draw a line in the sand for anybody that has been undergoing fertility treatment and hasn't been successful to make a decision not to move forward with any further fertility treatment. And I think that's, look, they're always hard conversations. They're not easy conversations to have, but I think that time comes when you've really investigated everything that you can for a couple. You've done everything that you can from an assisted conception perspective, and you're not achieving a positive outcome. And for a lot of couples, I always say, look, it may take at least 3 goes to achieve a positive result with IVF if couples have elected or individuals have elected and they're doing IVF treatment. And that might be a stimulated cycle and some frozen embryo transfer cycles. Now, after 3 cycles, and that gives, after a couple, you're getting a bit of a feel for patients, how they're responding. You're looking at, do we need to change anything? Do we need to do any further investigations? There are some patients, and you get to 3 cycles, and I might be able to say, look, I think we're going to get there, but we might just need another go. Maybe let's look at this or this. And so there's certainly some patients that are going to need more than 3 cycles to achieve a pregnancy, particularly if you're not getting large numbers of eggs. There are some patients, so you might get to the point where you may have done 7 cycles and we're not getting very many embryos, and we're getting poor embryo development. And we've really optimised all of those things that we've talked about tonight that might be helpful to achieve a pregnancy. We've looked at all those things. And then I think we need to be really honest and say, well, look, we're not achieving a pregnancy in the IVF setting. And so to keep pursuing IVF is not going to be in the patient's interests. and in the clinician's interest. You know, we don't want to give, I think as fertility specialists, false hope to patients if they're not going to achieve a pregnancy. It's really important to be honest, because there are other options for patients, because ultimately, you know, people, they're wanting to parent. And so there are other avenues that we, you know, that it's time, you know, that might be a good time to discuss, you know, in terms of, rather than, you know, in terms of the parenting route. Is it donor eggs? You know, okay, you know, is it donor sperm? Is it recurrent implantation failure? You know, and this isn't very often, but is it that someone might need to look at a surrogate in that sort of situation? Is it that, you know, the couple, I've often said to a couple, look, I think your chances conceiving naturally are now just as great as they are with IVF. And so that's why it's very important that you make sure you've maximised all of those opportunities naturally. So there is a point that comes where both, and I think until you're at that point, you're not going to know as a patient and, you know, clinician with the patients, but there is a point that you need to be honest and say, look, we've done everything that we could do, and, you know, we haven't achieved a positive outcome. And then it's time to have that conversation about, well, what are the other options for, you know, the patient or a, you know, or a couple.
What can do moving forward? And I think the tricky part is, you know, people in their might be 42, 43, even plus. And, you know, what a lot of people will find is that, you know, they stop, their cycles are being cancelled, and there's no eggs to be collected, or there's nothing mature.
Yeah.
Because it's kind of made for them, which is terrible. But, you know, it's probably a little bit easier to move on to that next donor conversation. I always find the patients really tricky when they might be getting 6 or 4 or 5 or 6 eggs, and they've got all these eggs, but they're still 44.
I think that's right. What I said earlier was been very helpful for us is when we've been able to do genetic screening on embryos. And so for patients that are, you know, 43, 44, and we are, and often, you know, and we are getting embryos to the day 5 day, it is sometimes a very helpful tool to say, well, let's test the embryos and see if they're normal. And particularly if you're still getting large numbers of embryos, but none of them are genetically normal, that's also a good guide to say, well, look, we're just not getting to where we want to be, you know, IVF process. So I think that's also been very helpful for patients over time, when we could actually have a look at some of the genetics of the embryo, which is probably an underpinning for a lot of patients, particularly over 40, why we're not getting a positive outcome. Now that's not all patients, but it can be helpful. And if you're not getting embryos to that stage of development, well, that also tells us that maybe we are running shy with embryo development. And again, if you've optimized all those other factors, that's another point in time to say, well, look, we're not getting our embryos to the blastocyst stage, which is why it's quite helpful. When I started, we were growing embryos to the day 3 stage, and it only just growing them to day 5. So get a lot more information about embryos. I think that's really helpful for patients, because we can relay that to them. And you know, Jay, you can actually see your embryos on an app, on the Grow app, see the development of your embryos. And I think that's amazing. And it's also very helpful for patients to understand when we get there on the day 5, saying, look, they just haven't reached that developmental stage, or only one has, and you can actually see how the embryos have progressed. And that's also very helpful, I think. Sort of say to patients, you know, if we've come to that point that we don't feel we're going to provide any more benefit with any more IVF.
What don't make it to that being able to be tested, right? And I think a lot of patients don't realise that. They're like, oh, we're going to IVF, we're 41 or whatever, we're going to be able to just do testing. Almost like just feel not get testing.
I think that's a really important, and look, we try and sort of tell patients about and even just, we don't always get an egg from every follicle on the ovaries, and that's you know, that can be very disappointing. They don't all fertilise. Only about 60 to 70, on average, about 60 to 70% of eggs fertilise, and less than half of those that fertilise are going to make it to the day 5 development day, and half of those for patients who are 40 may not be genetically normal. So it's really important to provide that counselling before undertaking IVF, because it may not provide pregnancy, and it doesn't for everybody that undertakes it. But it's so important to be realistic about expectations, you know, about what we hope to achieve for couples and what we can achieve for them.
Tricky one. We've got time for 1 or 2 more questions, because otherwise Instagram cuts us off and doesn't let us save, and I know everybody wants us to be able to watch it back. I was literally, this is probably a really big question, and you've got 2 feet in both camps. Well, 1 foot in each camp, not 2 feet in both. That'd be weird. Well, that'd be special if you could have 4 feet. The major difference between public and private IVF.
So I work at Royal Prince Alfred Hospital, and I've worked there for many years. That's in fact where I did my training. And I also have private rooms, so I send patients through Genea, one of the private IVF clinics. And I think the biggest difference between so there are some differences in the way the units run. The biggest difference is probably in terms of the cost, but it's also in the way the units run, the services that can be offered. So say, for example, at Royal Prince Alfred Hospital, we run a limited, so we have excellent fertility clinics. Patients can be assessed at the clinics if they require surgery for laparoscopes, and they're sort of guided through to one of our laparoscopic sort of specialists and will be reviewed and potentially put on operating theatre lists. You know, we do ovulation induction, we do IVF, we do known donors. We don't do any genetic testing of embryos there, so at this point in time we're not able to offer any aneuploidy screening, so the PGS, looking for the chromosomes, or single gene testing, things like cystic fibrosis, so we can't offer that there. The public service at the moment, there's a statewide initiative, so it's only $1,000 out of pocket expenses, which is such a good opportunity for IVF for patients. We run a pooled service at Royal Prince Alfred Hospital, so we have fellows who are just about finished their gynecology training, and we have a team of subspecialists who all do the clinics there, and we share the pickup list. So, say I'm on sort of every second Tuesday for the egg collection list, and I'll have a fellow in with me, and then we'll look at results, and then we'll do a clinic. So that's the way the unit runs there. And each unit's different. So Royal Hospital for Women has a public unit, and Westmead sort of has an association through the public hospital there with the clinic running through there. And so they're all part of the IVF initiative at the moment. So it's a great opportunity for patients. You do tend to see a doctor in the clinic, but it will be a different doctor that's going to be doing your egg collection and your embryo transfer, depending on the day of the procedure. And we do a lot of fertility preservation for cancer patients through the hospital. So all of the team there are very good at assessment and managing for those particular patients who come through the hospital setting. Every private IVF centre is different in terms of the way it runs, and different clinics will have different ways that they cycle patients through, and who looks after the patients. Through the fertility clinic that I send patients through, so through Genea, I tend to see the patients, and then we'll do their egg collection and their embryo transfer unless I'm away, and that does happen. So we do offer all the genetic services for patients. So we're able to do aneuploidy screening, we're able to do the single gene testing. We do a few stimulation and insemination through the private sector, which we don't offer through RPA, though I think you can do it through the Royal Hospital for Women. So the services run a little bit differently through the public versus the private, but both actually provide a really, we would hope, and they do a really high standard of care for patients, I think. There'll be some patients that will need that extra sort of time spent with them, and some additional therapies, and we don't offer some of those at the public hospital, and some of those immuno-based sort of protocols that aren't sort of supported by large randomized controlled trials. So some of those are not provided through the public sector.
Which is it's amazing that people have those options. It's not.
No, I think lucky. And RPA, I mean, they have been running for a long time, the services. I mean, perhaps they're not as well advertised, but they certainly have been running for a long period of time. And, they provide a really valuable service.
Amazing. Thank you. And thank you for working in both. Question, what's your sort of thoughts on day 3 embryos versus day 5? I mean, if there's only one embryo, or, if there's more embryos, what are your sort of thoughts? I mean, most day 5, but, yeah.
That's a really interesting question. And when this first all came up years ago, when we were looking at day 3 and day 5, there are some clinics that actually had very good day 5 results. They had very good blastocyst culture. They could culture embryos very well to day 5. So if you were working in a unit that didn't have that capacity, then you probably are still worse or better having a day 3 embryo transfer. So I think that's important, looking at the clinic's capacity to offer a day 5 embryo transfer, and the way that they culture their blastocysts. And I think we learnt that sort of early on, when the blastocyst, and it's getting a little bit more standardized, the culture media that's available, and there's still variances between the clinics. So that's one of the things that's important. Very interesting and so I tend to take embryos out to day 5 if we can, because you get more information about the embryos, and then if couples or patients are not successful, then you can guide, that information could guide you in making changes that might help if another attempt is required. Interestingly, we did a look at Genea at the pregnancy rates on this question. If you've only got one embryo, you better to put that embryo back on day 3 or day 5. And what we found is that if we only had one embryo, we did more embryo transfers. More patients would have a transfer on day 3 than they would on day 5, but overall there was no difference in the pregnancy rate. So what that tells us, if an embryo is going to make it to day 5, it probably is going to make it to day 5. So whether you put it back, day 3 or not, it isn't going, if you take it out to day 5, then if it wasn't going to make it, it just isn't going to progress to that stage. So if you can understand that concept. So I don't think there's what the important take home is that there's no disadvantage in taking an embryo out to day 5, even if there's an embryo. Fewer people will have a transfer, and that will be very, it's disappointing. It's a very disappointing outcome if you don't get to the embryo transfer. But what we would say in that situation is, look, had we put it back on day 3, then from the information that we've got from looking at this is that we don't think it would have achieved a pregnancy on day 3. So that's, I used to do a lot of embryo transfers on day 3 if there's only one embryo, and I do far fewer now for that reason also, for the very reason it's nice to have it to see actually whether the embryos are getting to the day 5 development stage to guide future treatment if it isn't successful when we're after the transfer.
Yeah. So a lot of it actually really does come down to the different clinic, but not just what they're choosing to do, but their culture, medium, and their actual capacity to help it to get on the stage.
Right. That's something for patients to discuss with their, with their clinic. Where the skill set, I suppose, is going to lie, and where they're achieving their pregnancy rates. And I think that's, every clinic's going to be different in that. And so I think everyone just has to take the advice of their fertility specialist with regards to that.
Yeah. Thank you so much for your time. I could chat to you like evening. Such long hours. You're absolutely everywhere. So thank you so much for taking the time to give us so much of your wisdom, answer everybody's questions, and as I said, just be here and, helping so many people achieve their goals of, a healthy full-term pregnancy. So thank you so much, Alison Gee.
Thank you for all the time that you spend with patients too. I know all of my patients that have seen you really, really appreciated that, and you give very, very sensible and very, very valued advice to them.
Thank you. It's good to have a team to kind of work with, which
is very important. That's very important what you've said. Yeah.
Thank you so much. So everybody will save this. Thank you for popping all your questions in, and we'll see you all next month. And Dr. Gee, I'd love to schedule you again at some point. But
no, nice catch up.
Yeah, exactly. We'll catch up as well. So thank you so much.
All right. It's been a pleasure. Thank you.
Great. Thank you. Bye.